Hi, I'm Dr Daniel Fleming. Thanks for your interest in breast implant surgery and for watching this video. There's two purposes to the video. Firstly, to help women who are interested in breast implants decide whether really they want to have them when they find out about the pros and the cons, the positives and the negatives. The second thing is, if you do decide you want to have breast implants, to give you information, evidence-based information to help you make the best decisions, not only to get the best result you can possibly get, but also to get the safest and the longest lasting result you can get. You know, lots of patients come to see me and they tell me the internet is really confusing. There's so many different versions of what's good and what's bad. Some sites and some surgeons might recommend textured implants and other smooth implants. Some surgeons will say go behind the muscle, some will say go in front. And it's really quite confusing, and sometimes it can be really difficult to distinguish what is really evidence-based fact from advertising hype. So having said that, how do you know this video isn't just advertising hype? Well, without wishing to boast, I do have quite a lot of experience in breast augmentation. I've been doing it for over 20 years, more than 5,500 patients. I've taught advanced techniques to plastic surgeons and cosmetic surgeons from all over the world. I act as a government expert advisor. I've published research and I've written chapters in books about breast augmentation. What I'm telling you in this video is based not only on my experience, but also on evidence. And it may be worth considering it as opposed to just relying on Dr. Google. Whether you realise it or not, when you go to a breast implant consultation, what your surgeon is doing is developing an operative plan for you. This means working out exactly how the operation is going to go for you. Not only the size of the implant, but also the type of implant, the surface, the shape, the positioning of the implant. All of these things are going to influence your final result. And there's no best one way to do it. It depends on what you look like beforehand. And we have to tailor these things to get the best result you can get, given what you want to achieve, and again, the safest and the longest lasting result. If you go through this video and you have a good look at our website, you'll have a lot of information to help you avoid the pitfalls that many women unfortunately make when making a decision about breast augmentation. There's going to be a lot of information here, so you may feel that you want to watch the video more than once. And also, I would strongly suggest to you that you make a note of questions that you might have so that you can take that along to your consultation and make sure that all your questions are properly answered by the doctor who's seeing you for the consultation. There are two different types of implants, basically. There are implants that are filled with saline, which is salt water, and there are implants that are filled with silicone gel. Not many doctors will recommend saline implants these days because the saline implants don't look and feel as good. They tend to ripple, particularly as they get older, and that gives a kind of waterbed effect, waterbed feel, and sometimes a waterbed look with actually seeing the rippling through the skin. Silicone, of course, has a bit of a checkered history, and over the years it's been thought that it might make people ill or make people sick, or whiz around the body and cause different kinds or exacerbate different kinds of diseases. We now know that that is completely untrue. It doesn't do any of those things. There were problems, though, with leaking silicone, particularly in the early generations of implants, because they were thin and flimsy and filled with a silicone gel that was too liquid. So not only did they break more often, but when they did break, the gel could run out. This caused localized problems in and around the breast, where the body would wall off leaking silicone and form lumps called granulomas, bits of scar tissue to wall off the silicone effectively. Now, these aren't dangerous, but they're a nuisance, and if they're big enough, they can become painful. Around about 15 years ago, two things happened. First of all, the covering of the implant was made much stronger, so it's less likely to break. And secondly, and very importantly, the gel was thickened up. It's called technically cohesive gel, and it looks and feels a bit like Turkish Delight. It's also known as gummy bear implants. That's exactly the same thing. There's no difference between a gummy bear implant and a cohesive gel implant. If these implants leak, because they're like Turkish Delight, the gel doesn't run out in the same way. You can still get leakage, you can still get granulomas, but it's much less of a problem than it used to be. Implants come in different shapes. You can get round implants and you can get teardrop implants. There's a misconception that if you choose a teardrop implant, it's going to look very natural and it won't have much fullness at the top. And if you choose a round implant, it's going to look implanty and very full at the top. That's not actually true. That depends on another aspect of the implants, which is called the profile or the sticky outness of the implant, which is another thing you're going to have to decide in your operative plan with your surgeon. But Interestingly, when studies have been done looking at patients who've had breast implants, and surgeons look at those patients and have to say whether they've had a teardrop or a round implant, the surgeons can't reliably tell who's got what. Without seeing the before photographs, you can't tell. So, if you can't tell the difference between round and teardrop implants, why would you ever use a teardrop? Well, the reason for that is that teardrop implants allow you to control 3 dimensions rather than just 2. With a round implant, all you can control is the diameter of the base, because it's round, and the profile or sticky outness of the implant. With a teardrop implant, you can control the height, the north-south distance, and the width, which is the east-west distance, independently. So you can have an implant that's taller than it is wide or wider than it is tall, as well as controlling the profile or sticky outness. If you do this, you can often get better results in a patient by being able to tailor the implant exactly to what they want and their own existing breast tissue. So having the option of teardrop implants and round implants allows your surgeon to work with you to get a result that's better than might otherwise be possible if you didn't have that choice. Another factor in the choice of implant is the surface of the implant, which can be smooth, textured, or polyurethane foam covered implants. Smooth implants are smooth like a plastic bag. Textured implants are where the surface has just been roughened up, looking a little bit like sandpaper. Polyurethane foam implants are a smooth implant that's covered with another layer of polyurethane foam. Another aspect of your operative plan will be placement of the implant. Where's it going to go? Well, thinking about the anatomy, starting from the inside out, you've got your ribs, then you have the pec muscle, then you have the breast tissue in front of the pec muscle, and then the skin and the nipple. You can put implants behind the muscle, that's on top of the ribs, or you can put them in front of the muscle so that they're behind the breast tissue, between the breast tissue and the muscle. Or you can go half and half, which is called a dual plane technique, where just the top of the implant is behind the muscle and the bottom is in front of the muscle. And we offer all 3 of those techniques. It's important to understand that there's no one way that's right. There just isn't. It depends on what you look like beforehand. There's no substitute for having an examination with an expert surgeon in the consultation to decide which of these positions is going to be right for you. But I can give you a general rule. As a general rule, if you're very thin or you have very little breast tissue, it's highly likely you're going to need to go behind the muscle. Because if you go in front of the muscle, there won't be enough of you to disguise the edge of the implant, and it will look very obvious, the so-called Victoria Beckham effect. If you've got more breast tissue and it's a bit saggy, then it's highly likely you're going to need to go in front of the muscle, because in front of the muscle the implant is closer to the breast tissue and it lifts it more. There's a few special cases where people need to go dual plane with the top behind and the bottom in front, and we'll be able to advise you about that at your consultation. What about incision sites? Well, obviously if you're going to have implants, there's going to have to be an incision made to put the implants in. Basically, there's 3 choices. You can go under the arm, you can go around the nipple, or you can go in the crease underneath the breast. What's been shown conclusively now is that the results are better and complications less if you make the incision in the crease underneath the breast, and that's what I would recommend for you. All patients worry about the scar, and that's quite natural and understandable. It's interesting though that after the operation, the only people who worry about the scar are people who have a bad one for some reason. Maybe they had poor healing, maybe they have a scarring tendency, for example. If you do get a bad scar, and that isn't common, I hasten to add, you'll still want to have it in the crease underneath the breast, because you will decide who sees it and when, and it won't be visible in clothes and bikinis. If you do have a bad scar and it's underneath the arm, you'll be embarrassed if you're wearing halter neck dresses or if you're wearing a bikini, for example. And if you have a bad scar and it's around the nipple, it'll be the only thing you notice when you look in the mirror. So given that, and the fact that the complication rate is less with an incision underneath the breast, most expert surgeons will recommend that route for your surgery. What about size of implant? Well, this is an area where people get really confused. In truth, there's absolutely no substitute for having a consultation with an expert surgeon, telling them or showing them in photographs what you want to achieve. The surgeon examines you and tells you what's possible for you. Then you'll try on a range of different sizes and shapes of implants and different profiles, in a crop top and perhaps in your own clothes as well, looking in a full-length mirror to see what it looks like. You may be surprised, because a lot of patients who come to see me say, oh, well, I think I want to have, for example, a 300cc implant because that's what my friend's got, or I've seen photographs on Google of 300cc implants. It looks about what I want to have. Well, that doesn't work, Because if you put a 300cc implant in 10 different women, they will all look different and many of them will have different cup sizes. Because the final result is a combination of the implant and your breast tissue on your chest wall. Because that's a unique combination and you have to have a unique operative plan for you to get the best result you can possibly get. So don't make the mistake of comparing your size with other people. Your friend might have 300cc implants, but you won't look like that if you have 300cc implants. Don't look on Google for 300cc, 400cc implants, whatever it is, and say, oh yes, I like that, so that's what I need to have. It won't work. You have to have a consultation with an expert and try the implants on after you've been measured to make sure that they're going to fit you. If you've had a consultation, you've decided to have breast implants and you go away, often what happens is patients will, in their dreams, they'll wake up in the middle of the night and they'll think, oh blimey, it's going to be too big or it's going to be too small. Then they'll go and talk to their friends and they'll look on the internet. Don't do it. Come back for another consultation and a resize. It's much, much better to do that because any other method of doing it is a poor substitute and likely to result in you choosing the wrong size. One other thing that I'll say about size is, if you get stuck between two sizes, you're not sure, should I have the 280cc implant or should I have the 310cc implant? As a general rule, if you're stuck in the consultation, you're not sure which one to go for, I would suggest you go for the larger one. Because what happens is, after the surgery, the breasts are a little bit swollen. And patients get used to that. And when the swelling goes away, sometimes they realise that they prefer the slightly bigger size. So if patients have a regret about size, it's nearly always that they went a little bit too small rather than they went a little bit too big. So if you're stuck between the two sizes, probably better to err on the side of going larger rather than smaller. And remember, there's only going to be about 30 mils. That's a shot glass between one size and the next. So if you do get it wrong, you're only going to be a little bit wrong. If you've got some sagging in your breasts, you're going to want to know, do I need a breast lift or not? Will I get away with implants alone? Well, again, there's no substitute for coming in, being examined by an expert surgeon, measuring your breasts to determine the real answer to that question. But I can give you some general guidelines about it. Of course, nobody wants to have a breast lift unless they really need one because there's going to be extra scarring, typically around the nipple and down to the 6 o'clock position, looking a bit like a lollipop scar. If you stand in front of a mirror and take your top off and look at your breasts sideways, if your nipples are at or above the crease underneath your breast, you're probably going to get away with implants alone and not need a breast lift. If they're below the crease, you're probably going to need a breast lift with or without implants as well. Another very useful guide is to stand in front of that mirror, but front on, and put your hands on top of your head with your fingers interlaced rather like this. As you do that, your breasts will lift up and your nipples will come up. And that is the height to which you can get your nipples with implants alone. So if at that point they're well above the crease and you're happy with the height of the nipples, then you're probably going to get away without a breast lift, provided the right operative plan is developed for you. People with heavier sagging breasts and implants will generally need to wear a bra most of the time afterwards, just as they did before they had implants. You can't turn somebody who's got sagging breasts into a gravity-defying 16-year-old, for example. And there's no point in looking at photographs of patients who are completely flat beforehand and expecting to get that kind of result. You need to compare before and after photographs of patients who are similar to you. On our website, we've got a range of different patients, some of whom do have sagging breasts, who were sort of borderline for needing a breast lift, who didn't want to have a lift because of the scarring and went with implants. And you can see a range of different results. What about the risks of breast implants? Well, this section is really, really important because there are risks. It's not a perfect procedure and you need to understand those risks before you decide to go ahead with breast implants. There's two types of risks. There's the general operative risks that would apply to any operation, whether you were having breast implants or whether you were having your appendix out. Anesthetic risks, for example. Poor scarring is another one. Then there's a second set of risks that apply just to this operation, to the breast augmentation operation. Leaking we've already spoken about. How common is it? Well, nobody knows for sure and it's probably different for different types of implants. But as a general guide, perhaps 1 in 10 patients by 10 years has got a leak, something like that. Remember, it's not dangerous. Most people who have one don't have any symptoms and they just find it because coincidentally when they have a scan for some other reason. The commonest complication by far of breast augmentation surgery is called capsular contracture. This is where the implant goes hard or goes out of shape. It happens because whenever you have an implant put in, your body will react by growing a membrane around it, a bit like a second skin to the implant. It's on the inside, you can't see it or feel it, and it surrounds that implant, walling it off from the tissue around it. Most of the time that membrane will remain the same size as the implant, and the implant feels normal and soft within it. But in a certain percentage of people, it will behave like shrink wrap, compressing around the implant, squashing the implant, making it go out of shape, making it feel firmer, sometimes making it feel rock hard like a stone and even being painful. Nobody knows for sure what the cause of capsular contracture is. There's various theories, but we do know it happens quite commonly. It used to be thought that textured implants would reduce the risk of capsular contracture, but we now know from data that's been developed in the USA by the regulator over there, the FDA, that in fact there's no difference between smooth and textured implants. They have the same rate of capsular contracture by 10 years. Capsular contracture isn't dangerous, but it's a nuisance and people obviously don't like it. If you're unfortunate enough to get capsular contracture, the only treatment is surgical. You need to remove the implant, you need often to remove that membrane that's behaved like shrink wrap and replace the implant. Another relatively common complication of breast implant surgery is bottoming out. That's where the implant slips down below the crease where it was originally. As it slips down, the nipple stays in the same position, so it looks typically like the nipple is too high on the breast because the nipple stayed the same and the implant has bottomed out or dropped down. Similarly, rotation can be a problem. This is where the implant spins. Now, if it's a round implant, it doesn't matter because you won't be able to tell. But if it's a teardrop implant, it does matter because it can look very odd indeed if a teardrop implant rotates. What about the risk of infection? Well, happily this is a low risk. There's two types of infection. You could have a wound infection where the scar only is infected, and that could result in a worse scar if it happens. Much worse would be infection in the implant cavity. This would be bad because if it happens, really you're going to need to remove that implant and leave it out for a period of time, probably about 3 months before you can put it back in. Luckily, these infections are very rare, less than 1% of patients who have breast implant surgery. Bleeding can occur in the post-operative period. This is typically in the first day or so and presents with a rapid and painful swelling of the breast, almost always on one side. It's called a hematoma. It's a collection of blood inside the cavity around the implant. If this happens, you must call your surgeon straight away. You'll probably need to go back to theatre to have the blood clot removed and to stop the bleeding. Fortunately, this complication is uncommon, happening in less than 1% of patients. Sensory changes in sensation, will occur with breast implant surgery. Usually they're temporary, but they can rarely be permanent. Typically what happens is there's an increase in sensitivity of the nipples for a short while and a patch of numbness between the nipple and the crease underneath the breast. The nerves are the slowest tissue in the body to recover, so improvement in sensory changes goes on for up to 2 years after your surgery. Permanent loss of sensation of both nipples can happen, but it's extremely rare. A particular type of risk with breast implants is called double fold, or double bubble it's sometimes known as. This is where you can see 2 creases underneath the breast. The first crease is the original crease of your breast tissue. The second crease is formed by the lower edge of the implant. Certain types of breast are more prone to this, and we'll be able to advise you in the consultation if you're at risk of it. If you are at risk of it, there are certain steps we can take in your operative plan, choosing the right shape of implant, the right plane of implant, how we actually do the surgery to minimise the risk of double fold. What about cancer? Well, it's been shown conclusively that there is no increase or indeed decrease in the risk of breast cancer in women who have any kind of breast implant. There's no doubt about that. Also, women who get breast cancer who have breast implants on average will find those cancers at the same stage as women who do not have breast implants. They do that through mammograms and self-examination. There is a rare type of blood cancer called ALCL. It stands for a long name, anaplastic large cell lymphoma. More easily said as ALCL. This is a rare kind of blood cancer that is more common with certain types of implants. The risk is still very low. Worst case, the risk is estimated to be less than 1 in 1,000 women with implants. To put that in perspective, the risk of any Australian woman developing breast cancer in her lifetime is about 1 in 8. The risk of any Australian developing a blood cancer in their lifetime is about 1 in 50, and we're talking about a risk here of less than 1 in 1,000. Nevertheless, it can happen, so you need to be fully informed. It typically presents with a swelling some years after the breast augmentation, which is a collection of fluid around the implant. Although most people who have a fluid collection don't have ALCL, that fluid should be tested to see whether or not you do have ALCL. Patients who do have ALCL, it's typically treated by removing the implants and the capsule or membrane around the implants. The same treatment, incidentally, that you have for capsular contracture. And usually that's curative and that's an end to it. There is a much smaller subgroup of people who have a lump as well as the fluid, and they may need to have more surgery. They may even need to have chemotherapy and radiotherapy, and most of those are cured as well. There is a tiny number of people in the world who have died from this condition. ALCL has not been seen with smooth implants. Most of the cases in the world have been seen with textured implants, and some cases have been seen with Brazilian polyurethane foam implants. How long do breast implants last? Well, there's no absolute answer to that question. But the general rule is, if they ain't broke, you don't fix them. So, for example, we don't say to patients, oh, you've had these implants for 10, 15, 20 years, you must have them changed. So no matter how long you've had your implants, if there's no complication and you're happy with them, you don't have to have them removed. There's no remove by date. However, it's very important to understand that no breast implant is a lifetime device. Sooner or later, there'll probably be some reason why you do need to have your implants replaced. So you can't go into having this operation assuming that you're never going to need any more surgery related to your implants. Many patients have had their implants for 10, 15, even 20 plus years and they're still happy with them. Pregnancy and breastfeeding. Well, for those of you who are considering breast implants before you've had children, you need to know what the likely implications of pregnancy and breastfeeding are. Well, most women who have breast implants and then have a pregnancy and breastfeed are still happy with the results of their breasts afterwards. Because although the breasts change with pregnancy and breastfeeding, just as they do if you don't have implants, if you've got implants, there's some scaffolding in there that's not going to change. Some women will not be happy with the look of their breasts after breastfeeding and pregnancy, even if they do have implants. That's typically because the breast tissue can sag away from the implant. If that happens, it's not because you have breast implants. It's in spite of the fact that you've got breast implants, because the breast implants have a lifting effect. You can then either replace the implants or you might consider having a breast lift to restore the height of the breast tissue to the height of the implant. Breastfeeding is perfectly possible when you've got breast implants. It doesn't matter whether the implant is in front or behind the muscle, because the breast tissue is always in front of the implant and there's nothing getting in the way of the milk travelling to the nipple. We use the recovery technique for our patients. I didn't develop this technique, but I did introduce it into Australia. It was developed in the USA by a plastic surgeon called John Tebbets, and when I first read about it, I didn't believe it. He calls it the out-to-dinner breast implants. Well, that's probably a bit of an exaggeration, though some people do that. We don't encourage it, incidentally. It revolves around using special operative techniques to minimise bleeding and minimise trauma to the tissues. This reduces pain, allows people to recover quicker. We've got some examples of patients who've had the rapid recovery technique and videos on our website, and please do have a look at those. Well, guess what? We used good ones on the website, but statistically your chance of being like those patients is something in the order of 65 or 70%. Obviously there is a normal distribution of patients. Some people are actually better than the ones on the website and some of them are worse. But wherever you're destined to be in your recovery from breast implants, you'll be better using the rapid recovery techniques than using more old-fashioned traditional techniques. Central to the rapid recovery technique is using an electrical scalpel to make the space for the implant. This reduces bleeding. If you can reduce bleeding, you reduce inflammation, you reduce pain, and you get a quicker recovery. About 50% of our patients say that they only need Panadol. About 50% of the patients feel able to drive a car the next day or go shopping the next day, for example. There's no special bandaging, just a little bit of tape over the wound. There's no strapping, there's no special bras. You're allowed to put your hands above your head immediately after the surgery if you wish, and you can lift weights of up to 10 kilos as soon as you feel comfortable to do so. Obviously there are certain things you can't do, lifting more than 10 kilos, contact sports, aerobics, really strong chest exercises. You're still going to need 4 to 6 weeks before you're going to get back into those kind of activities. We perform the surgery in a licensed day hospital. You'll be asleep while you have the surgery. That's a necessary part of the rapid recovery technique. One question that a lot of patients ask me is, when can I have sex? To which I usually reply, please wait till you get home. Seriously though, sex is no different to any other activity. You're not going to want to be involving your breasts in sexual activity for a few weeks after the surgery. But by about 4 to 6 weeks, your sex life should be back to normal, hopefully better than normal. If you do decide to have breast augmentation surgery, it's really important that you do have realistic expectations. When you look on the internet for pictures of people who've had implants and have a result that you like, make sure you look at the before photographs and choose people who've got breasts that are similar to yours to begin with. Take some of those photographs along to the consultation because it's going to help the surgeon to understand what it is you're trying to achieve. It's the job of the surgeon, first of all, to tell you whether that's possible, and if it is, to develop with you an operative plan that's most likely to deliver that result for you. Nobody has perfect breasts before or after breast augmentation. Minor asymmetry, for example, that was there beforehand will still be there afterwards. So if you're a perfectionist and you can't accept anything other than perfect breasts, then don't have a breast augmentation because it's not going to satisfy you. How do you choose a surgeon for breast augmentation, and how do you choose one that's right for you? Well, there's a lot of misinformation and indeed disinformation out there on the internet. What I suggest you do is you go to our website and read a whole section that we've written about choosing a surgeon. It's quite complex, this issue, and it's worth reading that. In there is a list of questions that you may choose to ask the surgeon in order to qualify them to make sure that they really are an expert in breast augmentation. One thing you should be aware of is this business about plastic and cosmetic surgeons. There's a lot of nonsense talked about that, and at the end of the day, it doesn't matter whether the doctor is a plastic or a cosmetic surgeon. What matters is, are they an expert in breast augmentation? Do you feel comfortable with them? Are they explaining things in a way that you can understand so that when they come up with the operative plan, you understand why each individual element of that has been chosen for you to try and optimize your result? On the website, you'll find those questions which we developed to help you work through with your surgeon to make sure that that surgeon is the right person for you. Because no breast implant lasts forever, eventually most people who have breast implants will need to have a secondary operation. There are special considerations with revision surgery. The risks are slightly higher and the results a bit less predictable. Even more than with first go surgery, every patient's situation is unique and you need to come in for a consultation for an accurate assessment before we can advise you any further about redo surgery. I've focused a lot on the risks of breast augmentation surgery so you can make fully informed decisions, but you'll be pleased to know that the vast majority of patients who have breast implants with me are satisfied with their results. If you want to go to the next stage, then please call our office and make an appointment for a face-to-face consultation. If you're a country, interstate or overseas patient, we can have an initial telephone consultation. To do this, you need to email us some photographs of your breasts, front and side on, and the contact phone number. This video has contained a lot of detailed information, some of it quite complex, so you may want to go back and review individual sections again, and we've organised it in such a way that you can do that. Also, again, I would say please do go and have a careful look at our website. That's got even more detailed information. It's a really valuable resource for women who are considering breast augmentation. Whatever you look like now, you're going to be able to find some information that's going to help you on the website.